Lecture number 5, fractures and dislocation of the long bones, clinical features. Fractures and dislocations. Fractures are cracks in bones. Symptoms including pain, swelling, ecchymosis, crepitation, deformity, and abdominal motion. Occasional complications include fat embolism, arterial injury, compartment syndrome, nerve injuries, and infection. Diagnosis is by clinical criteria and usually plain X-ray rays. Treatment involves analgesics, immobilization, and sometimes surgery. Most fractures result from a single application of significant force to otherwise normal bone. Pathological fractures result from application of mild or minimal force to a bone weakened by a disorder such as cancer, cysts, or osteoporosis. Stress fractures, like metatarsal stress fractures, see exercise and sport injury, stress fractures, result from repetitive application of force. Pathophysiology. If K and vitamin D levels are adequate and bone tissue is healthy and the fracture edges are kept reasonably close to each other and with little or no relative motion. Most fractures heal within weeks or months via remodeling. New tissue callus as produced within weeks and bone rehabs at variable rate during the first weeks or months. Ultimately, optimal remodeling requires gradual resumption of normal motion and load bearing stress. However, remodeling can be disrupted and refractory and occur if force is applied or the joint moves prematurely. Thus, immobilization is usually needed. Serious complications are usual. Arteries are injured usually in the closed supracondylar fractures or of the humerus and femur, but rarely in other closed fractures. Compartment syndrome or nerve injury may occur. Open fractures predispose to bone infection, see infection of joint and bones, osteomyelitis, which can be intrastable. Fractures of long bones may release fat and other marrow contents that embolizes to the lungs and causes respiratory complications. See pulmonary embolism. Fractures that extend into joint usually disrupt articular cartilage. Misaligned articular cartilage tends to scar, causing osteoarthritis and implanting joint motion. Occasionally, fractures do not heal, call it non-union. Rarely, non-union occurs even when treatment is expeditious and correct. If the vascular supply is injured by the initial injury, such as a scaphoid fracture. Uh, Aseptic necrosis may ensue even if the fracture was properly immobilized. Symptoms, signs, and diagnosis. Pain is usually immediately. Swelling increases for several hours. Children may not exhibit significant soft tissue swelling in the presence of a fracture, Baxter Torres, a fracture of a green stick fracture. Pain and swelling usually begin to resolve after 12 to 24 hours. Uh, Worsening pain after this period suggests compartment syndrome. All the symptoms and signs may include bone, tenderness, ecchymosis, decreased or abdominal motion, deformity, and crepitation. With some fracture, like rib fracture, motion can be censored by the patient and is described as a popping or cracking sensation. Patient with finding that suggests fracture are examined for ischemia, compartment syndrome, and nerve injury. If a wound is close to a fracture, open fracture is assumed. Fractures are diagnosed by imaging beginning with pain X-ray. If no fracture line is obvious, bone density, trabecular pattern, and cortical margins examined for suitable close to fracture. If a fracture is not visible on plain X-ray but is strongly suspected, or if more detail is needed to guide treatment, MRI or CT is done. Some expect recommended imaging the joint proximal and distal to the fracture. Fractures appearance on X-ray can be described precisely using 5 terms. Common types of fracture lines. Transverse fracture are perpendicular to the long axis of bone. Oblique fractures occur at an angle. Spiral fractures result from a rotatory mechanism. On X-rays, they are differentiated from oblique fracture by a component parallel to the long axis of bone in at least one view. Completed fractures have more two bone fragments. Comminuted fractures, including segmental fractures, two separate break in the inner bone. View lesion fractures are caused by a tension dislodging a bone fragment. In impacted fractures, bone fragments are driven into each other, strengthening the bone. These fractures may be visible as a focal abnormal density and trabecular or irregular in bone cortex. Childhood fractures include torus fragments, buckling of the bone cortex, and the green stick fractures, crack or in only one side of the cortex. Distraction, displacement, angularization, or short tensing, overhealing, they occur. Distraction is a separation in the longitudinal axis. Displacement is a degree to which the fractures ends are out of alignment with each other. It's described in millimeters or bone weight per percentage. Angulation is the angle of the distal fragment measured from the proximal fragment. Displacement and angulation may occur in the ventral dorsal plane, lateral medial plane, or both. Tip fractures line, fractures dislocation and splines, common tips of the fractures line. Local or fracture line angulation, displacement, fractures dislocation, and spline. Spatial relationship between fracture fragment, open or closed. Location may be the bone's head, sometimes involved articular surface, neck or shaft, proximal, middle, or distal third. Treatment. Immediately treatment included analgesics and for suspected unstable fracture or fractures of long bones splinting. Suspected open fracture require sterile wound dressings, tetanus prophylactics, and broad spectrum antibiotics. Leg two generation cephalosporin plus and aminoglucoside. Rotational malignant or significant angulation or displacement is corrected with reduction, realignment of bone fragments by manipulation. Experience includes some diaphysis fractures in children. In these fractures, remodeling gradually corrected some types of significant angulation. and end-to-end realignments of fracture bone fragments can stimulate bone growth, which may then be excessive. Close reduction without skin, including incision, is done when possible. Is not open reduction with skin incision is done. In open reduction and internal fixation, fracture fragments are angelus and held in place using hardware. RF is usually indicated for the following. When an intra-articular fracture is displayed to precisely link the joint cartilage, when RF has been shown to have better result for the particular type of fracture, when closed reduction was ineffective, when the fracture traverses a canerous lesion because the normal bone healing does not occur. When prolonged immobility required for callus formal and remodeling is undesirable egg for hip fractures because RF provided early structural stability, which facilitates mobilization. Surgery is required when injury to a major vessel is suspected for vessel repair, or when the fracture is open for irrigation and debridement to prevent infection. Open reduction may be done without using hardware when closed reduction is ineffective. Fracture, whether they require reduction, surgery, or neither, are typically immobilized, as are the proximal and distal joint. Usually, a cast is plated for weeks or months, but a splint may be used instead, particularly for fractures that heal fast when mobilized early. Home care for fractures includes separative measure such rest, ice, compression, elevation, C, fractures, dislocation, and spread, RICE. Patient are told to seek care immediately for if symptoms of compartment syndrome occur. See fractures, dislocation, and sprains, compartment syndrome. And genetic essentials. The elderly are predisposed to fractures because of osteoporosis, a tendency to fall fragmentally, and drug side effects, and impaired protective reflexes during falls. Age-related fractures tend to affect the metaphysics, the flared area between the end and shaft. They include fractures of the distal radius, proximal humerus, proximal tibial, proximal femur, pubic ramus, and vertebral. The goal of treatment is a rapid return to activities of daily living rather than a restoration of prefect limb alignment and legs. Because immobilization and joint immobilization or bed rest is more likely to cause adverse effect in elderly, use of ORIF is increasing. Early mobilization and physical therapy are essential to recovery of function. Causing disorders, leg articular scan, and interfere with recovery. Specific fractures. Stress fractures. Stress fractures are small and result from repetitive force leg from oversize. They occur most often in the metatarsal, usually in runners, exercise and sports injuries, stress fractures, followed by the tibia and fibula. Symptoms include gradual onset of intermittent pain and worsens with weight bearing and eventually becomes constant. Sometimes swelling occurs. Examination defects localized bone tenderness. Plain X-rays are born but may not show the fracture at first. Thus, many such fractures are treated presumptively, and plain X-ray is repetitive. 2-3 weeks later, when colors may be visible. Treatment is rest elevation, analgesics, and sometimes immobilization. CT or MRI is rarely needed. Growth plate fracture. Bone growth as a tissue is adjusted proximally by the epiphysis disc, growth plate, which is bordered by the metaphysics proximally and the epiphysis distally. See Figure 4, fractures, dislocation, and sprained epiphysis disc ground plate. The age at which the ground plate close and bone grown stops varies by the bone, but the growth plate is closed in all bones by the end of puberty. If there is questions about a growth plate injury or if a fracture is suspected opposite side, comparison X-ray may be helpful. The ground plate is most frequently a part of the bone, and truss is usually the first structure disrupted when force is applied. Ground plate fractures are classified by the Saltes-Harris system. Fractures dislocation and splint Saltes-Harris classification of epiphyseal disc ground plate fractures. Disruption of future bone grown is common with type 3, 4, and 5, but uncommon common with types 1 and 2. Salter-Harris classification of epiphyseal disc ground plate fractures. Type 1 throws 4 are physeal fractures. The ground plate is separated from the metaphysis. Type 2 is the most common, and type 5 is the least common. Ground plate fractures as suspected in children with tenderness localized over the ground plate. The fractures cause circumferential tenderness, and truss can be clinical differential from contusions. In fracture types 1 and 5, X-ray may appear normal. If so, the fractures can sometimes be differential from each other by injury mechanism like destruction, separation on the longitudinal axis with compression. Close treatment is usually sufficient for types 1 and 2. RF is often required for the type 3 and 4. Patients with type 5 injuries should be referred to a pediatric orthopedics because such injuries almost always lead to grown abdominalitis. Rib fractures. Typically, rib fractures result result from blunt injury to the chest wall, usually involving a strong force, from high speed, acceleration, and visible but major fall. However, sometimes in the elderly, only mild or moderate force, like in a minor fall, is required. Concomitant injuries may include aortic, subclavian, or cardiac injuries. Uncommon, but can occur with high-speed deceleration, particularly if rib 1 or 2 is fractured. Splenic or abdominal injuries with fracture of any of rib 7 through 12, pulmonary laceration or constriction, pneumothorax or the tracheobronchial injuries uncommon. Pain is severe is aggravated by movement of the trunk, including cold or deep breathing, and lasts for several weeks. Inspiratory splinting, incomplete inspiration diet or pain can cause atelectasis and pneumonia, especially in the elderly or those with multiple fractures. Young health patients and those with one or two rib fractures readily develop their complications. Palpation of the chest wall may identify some fractures, and sometimes the patient and the examination clinical can feel the broken ribs more when the lung is expanded. A chest X-ray is taken thoroughly to check for concomitation injuries, pneumothorax, pulmonary contusion. Many rib fractures are not visible on a chest X-ray. Specifically, rib review may be needed, but identify all rib fractures by X-ray is not always necessary. Other tests are done to check for concomitant injuries that the clinically suspected. Treatment required opioid analgesics, which can distress respiration and worse atelectasis. To minimize pulmonary complications, patients should consciously and frequently exhaustively breathe deeply or cough while awake. Holding, essentially splinting the affected area with the flat palm of the hand or a pillow can help minimize the pain during deep breathing or coughing. Patient hospitalized if they have more three fracture or underlying cardiopulmonary insufficiency. Immobilization, by strong or stepping, should usually be avoided. Is a constriction, respiration, and may predispose to atelectasis or pneumonia. Clavicular fracture. The usually injury mechanism is a fall on a outstretched arm or direct blow. About 80% involve the middle 1.3 of the bone and the immobilized which sling. Previously used figure of the H bracelet are no more helpful and are more uncomfortable than a simple sling. Reduction is not necessary even for greatly angulated fractures. Clavicular fractures that significantly tend to the skin or that involve areas other than the middle 1.3 of the bone may require additional intervention. Proximal humerus fracture. The usual injury mechanism is a direct force or fall on an outstretched arm. Usually, displacement and angulation are minimal. Contracted by develop after only a few days or immobilization, particularly in the elderly. Minimally displaced or angulated fractures are treated with immobilization in a sling and sway, and earlier range of motion exercise. More severe fracture might require ORIF or surgery to insert a prosthetic joint, shoulder replacement. Distal humerus fractures. The usual injury mechanism is a direct force or a fall on an outside arm. The brachial artery or radial nerve may be damaged. Angular, if present, must be corrected. Casting with closet reduction may be treated, but ORIF may be necessary. Radial head fracture. The usually injury mechanism is a fall on an outside arm. The radial head is palpated on the lateral elbow as a structure that rotated during pronation and supination. Rotating antero-posterior and lateral X-ray usually show a joint effusion or a displaced anterior fat pad cell-sink, but others do not show the fracture. Patient with localized radial head, tendonless and affection require oblique view, which are more sensitive for fracture, or preoperative treatment or fracture. For fracture with only minimal angulation and displacement, treatment is a splint which the elbow flexed 90 degrees or a sling. Arthrocentrics to the remove blood from the joint also helps relieve pain and facilitate recovery. Starting range of the motion exercise 10 days after the injury maximizes joint flexibility. Distal radial fractures. The usual injury mechanism is a wrist hyperextension, usually during a fall. Dorsal displacement of angulated fracture, sometimes called fracture, are common. Treatment is a reduction and immobilization at 15 to 30 of wrist extension. ORIF may be necessary if the joint is disrupted or if there is excessive impactment or shortening. Metacarpal neck fracture, except trump. The usual injury mechanism is axial load, egg from punching with a clenched fist. If wounded or near a metacarpophalangeal joint, contamination with humoral oral flora should be considered and measured to prevent infection or other required. See bit at string antimicrobial reduction is necessary for fractures of the 1, 2, and 3 metacarps, but unnecessary for dorsal or volar angular of more certifies for the false metacarpal or of 45 for the 5th metacarp. Treatment is a splint egg and unlar gut splint for the fracture of the 4th and 5th metacarpal. Fractures, dislocation, and spleen, joint immobilization, and acute treatment. Some commonly used techniques. Scaphoid fractures, navicular fractures. The usual injury mechanisms is wrist hyperextension, usually during a fall on the outside hand. Avascular necrosis is a common complication, even when initial care is ideal and can cause disabling degenerative articularis is the wrist. Fractures signs include pain with axial compression of the trunk, pain with wrist supination against wrist strains, and particularly tenderness in the anatomic snuff box with ulnar wrist deviation. The anatomic snuff box is palpated just distal to the reduced between the extension pollicis longus, extensor pollicis brevis, and abductor pollicis longus tendons. The initial pain X-ray is also normal. If a fracture is still suspected, MRI, which is more sensitive than X-ray, is done or fracture is presumed and treated with a Trump speaker splint. With a follow-up plain X-ray taken in a 1 to 2 week. Rarely, this sub-square X-ray is facility normal. Finger tip top of the distal plantar phalanx fractures. The usual mechanism is a cross injury, subangular venous the nail, hematoma usually acute and produces blue-black tint brows, which may elevate the nail. Hematoma indicated a nail bed laceration. Most fingertip fractures are treated symptomatic with a protective covering, commercially and available aluminum and for splint material. Wrapped around the fingertip. Subangular hematomas can be drained. They relieve pain by puncturing the nail. Terrification, usually with a 18 guide needle in a rotatory motion, or if no nail polish is on the nail with the electrocautery device. If therapeutic is done gently and rapidly, anesthesia is also unnecessary. Large displaced fractures are rarely repaired surgically. Markedly disrupted nail beds are repaired with surgery, but are best left alone if the nail is closely adhered to the nail bed. Hyperpresthesia frequently persists long after the large fracture has healed and requests desensitivity therapy. Pelvis fracture. Pelvis fracture may be stabile and unstabile. Compression of the pubic symphysis or seminal toenails, compression of both anterior superior iliac spines is often painful, particularly is severe fractures. For pelvis fractures, CT is more sensitive than plain X-rays. Stability fractures don't disrupt the pelvis ring. Some like symphysia or pubic rhymes fractures result from minor injuries, leg falls at home, especially in a patient with osteoporosis. Treatment is often symptomatic, particularly if patient can walk unaided. Unstable fracture disrupt the pelvis ring in a more two places. Description can be fracture with bone or separation between the fibrous joint, syndesmosis between bones. Unstable fractures usually result from sustained steel force, leg, high-speed motor, vehicle conditions. Interstitial injury may occur. Concomitant GU injuries are common, particularly with anterior pelvis fractures. Vascular injuries may occur and cause hemorrhagic shock, especially with posterior pelvis fracture. Mortality rate is the highest. Initial evaluation and treatment are directed as associated injuries. The fracture often requires surgical repair. Hip fractures. Hip fractures are most common among the elderly, particularly those with osteoporosis, mostly women with osteoporosis. Most fractures result from fall, but in the elderly, similarly, minimal force can result in a hip fracture, usually because osteoporosis has weakened bone. Subcapital femoral neck and the intertrochanteric fragments are the most common tips. Hip fractures also cause referred pain in the knee and so maybe a mini period as knee abdominality. Pubic ramus fractures can produce hip pain. Subcapital fracture may result from a signal injury, but often result from a repeated stress or minimal force. Resulting is a small or large stress fracture. A fall after the initial fracture may worsen or displace the fracture. Patients with small fractures may be ambulatory and have only mild pain. However, such patient may be unable to flex the entire lower limb against resistant with the knee extended. Passive hip rotation with the knee flexed aggravate the pain, helping to differentiate a hip fracture from extra-articular disorder, such as trochanteric bursitis. Large or displaced fractures tend to limp hip motion more, shorten the leg and cause the leg to rotate externally. Displacement predisposes to osteocrosis or the femoral head and fracture non-union. Plain X-ray are occasionally normal when fractures are small or impacted or when osteoporotic is severe. If a fracture is still suspected, MRI is done. If MRI is unavailable or contraindicated, CT is done. If patients are expected to resume walking and have no contradictional to surgery, treatment is usually surgical repair, typical RFC. If and early ambulation. If patients are elderly, not active, and have displaced fracture, treatment is also prosthetic replacement of the femoral head, typically with a more prosthesis or total hip replacement. Occasionally, the femoral head must be replaced when the fracture of displaced in younger adults, particularly those who are inactive. Usually, prolonged bed rest should be avoided in elderly patients. Bed rest increases the risk of the deep venous thrombosis, a common complication of hip fractures. Prophylaxis, prophylactic anticoagulation may reduce the inclusivity of post-hip fracture venous thrombosis. Intrachanteric fractures usually result from the falls or direct blows. Patients have tenderness, ecchymosis, and swelling over the hip. Usually the leg is short-tended and rotated externally. Plain X-ray are usually diagnosed. Treatment is usually RF and early mobilization. Femoral shaft fracture. The usual injury mechanism is severe direct force or an axial load to the flexed knee. Fracture due to trauma caused obvious swelling, deformity, and instability. Up to 1.5 long of blood for each fracture may be lost. Treatment is immediately splinting or then ORIF. Ankle fracture. The ankle bones and ligaments form rings connected the tibia and fibula to the toes calcaneus. Within the ring, stability is provided by two bones, the medial malleolus of the tibia and lateral malleolus of the fibula, and two ligaments completed, medially and deltoid ligaments. Laterally, mainly the anterior and posterior tibiofibular ligaments and calcaneofibular ligaments. Ankle fracture and common and can result from multiple injury mechanisms. Fractures and disrupt the ring in the one place, often disrupt it in another. If fracture disrupt more two of the structured stabilizing and the ankle ring, the ankle is unstable. Description of the medial deltoid ligament also caused instability. For stability, the injury surgery may be required and prognosis is required. Most stable ankle fractures without other indicated for surgery can be treated with a cast for 6 weeks. Prognosis is good. Fractures of the Tunes metatarsal bone base with dislocation. With Frank's fracture dislocation. The usual mechanism is a fallen foot in a plantar flexion. Usually there is significant soft tissue swelling. There are fractures are difficult to applicate it on plane X-ray and are often misdiagnosis, leading to sometimes serious complications such as osteoarthritis and rarely compartment syndromes. A plain X-ray can show a fracture at the base of the tuned metatarsal or sheep fractures of the cuneiform, but may not show disruption of the tarso-metatarsal joint, which should be suspected even if it is not visible on plain X-ray. Dislocation often spontaneously reduced but immediately referral, usually for closet reduction, which requires general anesthesia, may be warranted. Fracture of the fifth metatarsal bone base, dangerous fracture. The usual injury mechanism is a twist, typical inversion, or crush injury. The fractures usually heal relatively quickly, non-union, and is uncommon. Treatment is a preparative walking sure. Fracture of the fifth metatarsal bone, diaphysis, joints fracture. The usual injury mechanism is a crush injury. The fractures are less common than those of the metatarsal bone base, and delayed union or non-union cubes more commonly. Treatment is a cast and mobilize the ankle. Avulsion fractures of the base of the fifth metatarsal can occur with the inversal ankle injuries and are less significant than true joints fracture. The latter being predisposed to non-union. True fracture, toe fracture. The usual injury mechanism is a crush injury, unless rotational deformity or joint involvement is suspected, or the proximal phalanx of the great toe is injured. X-rays are usually unnecessary. Treatment is taping the injured toe to an adjacent toe, dynamic splinting, or body taping. Markedly displaced toe fractures should be reduced to restore alignment. Clinical evaluation of the injurious limb. Physical examination of the injurious limb, inspection, palpation of movement, examine the bone of the instability and examine the soft tissue of the associated injury, document neurologic and vascular status. Clinical feature of fracture, pain and tenderness. All fractures cause pain neurological in function. Pain and loss of structural integrity of the limb cause loss of function. Deformity, change in late angulation, rotation, and displacement. Attitude. The position of the fractured limb is sometimes diagnosis. The patient with a fractured clavicid usually supports the limb and rotated his head to the afterward side. Abdominal mobility and crepitated. The signs should not be those the liability because pain and injury may result. Clinical feature or dislocation. A dislocation occurs when the articular surface of a joint are no longer is contact. Subluxation, particular dislocation, is a less severe condition that occurs when the orientation of the surfaces is altered, but they remain in contact. Pain on and tenderness. Severe pain may be completed, relieved when the joint is relocated. Loss of motion. Both active and passive motion are limited is the dislocation. Loss of a normal joint contour is in the anterior dislocation shoulder, the devolved flattened and the greater tuberosity of the humerus is the longest lateral to the acromion. Attitude. The patient carefully holds the anteriorly dislocated shoulder in abduction and external rotation. Neurologic injury. The indicator of neurologic injuries is most highest with the dislocation with the than with fractures. Shoulder dislocation are often associated with axillary nerve injury. Posterior dislocation of the hip can result in a sciatic nerve contusion. Careful examination for neurologic status is indicated before and intervention. Clinical description of fracture, anatomic location, metaphysical at the flat of the bone, diaphysis, fracture through the diaphysis, proximal, middle, or distal third of the shaft, epiphysis, fracture and at the end of the bone, Salter, classification of fracture, children. Type 1, fracture of throat physis between the epiphysis and metaphysis. Type 2, fracture throat physis involving the metaphysis. Type 3, fracture throat physis involving the epiphysis. Type 4, fracture throat physis involving the metaphysis and epiphysis. Type 5, crush injury to physis between the epiphysis and metaphysis. Bone deformity. Describe any change in bone ledge, angulation, and rotation and displacement. Direction of the fracture line. Describe the radiographic direction of the fracture. Transfer the perpendicular to the long axis of the bone. Oblique fracture is at an angle to the bone. Spiral occurring secondary to torsional stress. Comminution, fracture with more than 2 fragments. Open or closes. In an open fracture, the bone protrudes through the skin. Green stick fracture. One cortex is broken with the other remains intact. Radiographic evolution of fractures. A minimum of 2 views at ring angles to each other should be obtained. Visualize the joint above below the injury and check for soft tissue swelling. Views of the injured extremity are often usual for composition in children. Management of fracture. Fracture or reduction. The fracture must be restored to a normal anatomic position. Muscular spasm should be relieved with traction and analgesics and muscular relaxants. Bone must be is a position property, a ligament, and ligament and rotatory description, and set to proper length. Fractures must be held in a place with a splint or cast. Indication for operative treatment. Future or closed method to reduce or maintain reduction of the fracture. Displaced intra-articular fractures where the fragments are sufficiently large to allow internal fixation. Multiple injuries in a multiple trauma patient. Operative treatment can allow early mobilization. Early immobilization can sometimes avoid the mobility and mortality associated with prolonged recumbency. Upper extremity fractures on dislocation. Distal radius fracture is often associated with fracture of the ulnar styloid. Treatment consists of the close reduction, casting, and elevation of the extremity until swelling subsided. After the reduction, check alignment with an X-ray and rule out medial nerve injury. Forearm shaft fracture. In adult result and ulnar shaft fractures require open reduction and internal fixation. Humerus fracture, X-ray the anterior bone and check for the radial nerve injury, wrist drop. Humerus fractures are usually treated with a collar and cuff sling of coaptation splint. Clavicular fracture, subclavicular, articular, and brachial plexus injury may occur. The fracture should be splinted with a figure and H bandage or sling. Clavicular rupture rarely requires surgery. Anterior shoulder dislocation occurs when the humeral head has been forced anterior to the glenoid. It is usually caused by external force applied to adducted arm. The patient present with the arm in signed abduction, and he cannot bring his elbow to the side. There is a slightly depressed deltoid prominence, and arm motion causes pain. Axillary nerve injury may occur, causing a serious difficulty over the deltoid. Treatment consists of reduction with gantry traction. Posterior shoulder dislocation occurs when the humeral head has been forced posterior or the glenoid. Dislocation may occur secondary to series of electrocution. The arm is held in adduction with internal rotation. Treatment consists of reduction with glantal traction. Low extremity fractures and dislocation. Femoral neck fractures. Osteoporotic bone predisposed to this intra-articular fracture. Internal fixation or endoprosthesis are required. Intertrochanterical fractures usually occur in the elderly after fall. The fracture is located outside the joint capsule. Treatment consists of internal fixation. Femoral shaft fracture. Early intramedullary nail is recommended in adults. This fracture is rarely associated with fat embolist syndrome. Patellar fracture. If the bone is non-displaced, it can be treated in a cast. If it is displaced more than 2 millimeters, it should be treated with internal fixation. Quadriceps function should be checked. Tibial shaft fracture can be treated crossed or with internal fixation. Ankle fracture. Evaluate the stability of the ankle fracture by examining the joint space between the toes and tibial plafond. Unstable injuries require internal fixation. Knee injuries, knee ligaments testing, varus valgus femur stress test. The examiner stabilized the femur and pressure the extended outward or inward at the ankle. A treat of the collateral ligament is indicated by excessive mobility. Anterior draw test. Pull tibia anteriorly with the knee flexed 90 degrees to test for tear of anterior cruciate ligament. Posterior draw test. Push tibia posterior with the knee flexed 90 degrees to test for the tear of the posterior cruciated ligament. The most common ligament injuries are treating of the medial collateral ligaments by a flow from the lateral side of the knee and tear of the anterior cruciate ligament between or on a planted foot. Brace immobilization is usually sufficient for medial collateral ligament tears. Dislocation of the knee often results in a multiplate ligament injury. Popliteal arterial trauma should be excluded. Immobilization of the knee followed by ligament reconstruction should be completed. Thank you for the attention.